Good afternoon, everyone. From the economics of ours, this is about economics of mobile diagnostic van, what we are using. You must have heard about cost benefit, cost effectiveness, or cost utility analysis, and also the cost minimization. So there are various interventions either in the monetary form, the gains may be in terms of cash or quality of life, and there are certain concerns. So these are the terms which are commonly used in health economics. We know that the number of people with vision loss is growing as per the IAPB atlas, which is there on the net, and it is going to increase to 780 million. And also the patients who are going to have diabetic retinopathy, what we have seen today in the morning, and also from the literature. So number of patients having vision-threatening diabetic retinopathy or having some amount of retinopathy is going to increase. We have shown that risk factors for poor vision in our Andhra Pradesh eye disease study as age, female, illiterate ones, those who have lower level of education, smokers, and alcoholics. And this high incidence, initially we thought that it reflects the poor access to eye care, and that is what the genesis of LVPI's eye health pyramid, what we have in 4 states, including state of Andhra Pradesh. We have a tertiary center here at Vizag. We know that mobile units have been used in areas of tsunami, earthquake, patients who have diabetic projects are running in India, mobile vans for x-rays, and also dental clinics on mobile van. So this is about mobile diagnostic van, what we have with the diagnostic equipment. The purpose here is to report the diagnostic van model for doing diagnostics in the secondary centers in remote, rural, and indigenous areas. We started this in this state in Andhra in August 2019. I'm going to present here data of Jan to December 2022. We have 2 types of investigations, like fixed facility where we will have all investigations at one place and patient will be moving. And we have a van where the van carries all the diagnostic equipment and moves from one village or one center to the other center. Based on the investigations, we can manage patients either locally or we may have to refer them to higher centers, as this information would lead a more tailored treatment for the patients. So these are the various equipment which we have used in the van. And based on the equipment and the vehicle cost, the total cost of the van is 1 crore 11 lakhs. And the investigation and charges in the rural setup would be lesser compared to what we have in metro cities or tertiary centers. So there is definitely a difference in that. And various subspecialties would have certain investigations. And this is the cost of running the van. If we remove the cost of admin, this cost would still go down to, say, 65,000. Considering for the patient, the transport costs, the daily wages, whether patient has to have a single trip and we can take care of that, or multiple trips to higher center. This was IRB approved study. The study period, as I said, is Jan to December. 5 centers each in Orissa, Andhra, and Telangana state were included. And we had these are the number of visits and patients, because one patient may have more investigation compared to the other one. We had a few patients who were following up with us and then we did investigation, or patients who had come to us for the first time, we did investigation and then we didn't have to have their visits for future. So these are total 2470. We could manage 90% of patients locally and we just had to refer 9.96% of patients. As you can see here, most of the patients are like above the age of 60 years, because these are the patients who would need someone to accompany them, and they have to go to tertiary center, so we could take care of them. 46% of female, 47% of investigations what we have done are non-paying, and 90% patients had multiple visits earlier with us. So we could manage 90% of patients and had to refer only 10% of patients. And most of the investigations what we have done are for retina, followed by glaucoma and other investigations. So these are again, based on their first visit, we could still take care of most of the patients, and only 9.9% patients had to be referred. Subspecialty wise, if we see, 82% could be managed for cornea at secondary center itself, and these are the various percentages, and only 90% we had to 90% we could manage for anything whatever we say. So if we consider that, we could avoid on an average 3 visits to tertiary center for these patients, and we could save the amount of money for these patients. The average cost saving per patient, if we include wage and travel cost, was also, as mentioned, 7,600. So if we consider that capital lasts for 5 years, the annual cost is 1 crore 11 lakhs, and staff cost, if we reduce the admin salary, then it is just 65,000. So cost per patient in our study was 912 rupees. And because we started one van late, as we continue sending these vehicles to the secondary center, probably with more number of investigations, this cost will go down further in future. So we could reach the target population where symptoms was known and we had to do investigations. We could advise those elderly people who have comorbidities like diabetes and blood pressure are taken care of in this. And if we have a faculty visiting there, we can take care of those patients at that time. Because of if faculty is around, we can take the decision immediately. But with the teleconsult facility, what we have now, we can still do that, whether the faculty is there or not. And we can avoid the visits for the patients. If we think that we just want to do for retina only or for glaucoma only, then it is very difficult to for the cost recovery from one van. And HR also is needed. Vehicle sometimes breaks down and we have to take care of those things. This is just to give you an example. On a clinical examination, when we could see a split reflex, we had done investigations like topography and pachymetry, and then, as we all know, we could identify keratoconus and take care of the patient. So this is how probably we can help the patient in a better way. So we can avoid patient's visit and we can save money for the patient. We can manage them locally. When required, we can refer them. Locations based on the disease, we can change if required. And investigations can be added, because initially we had added specular also, but we had hardly done 6 speculars in the beginning, so we had stopped that, and referrals can be looked into. These are just the photos of vans.
Excellent presentation.
Thank you
Very much.